Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for a commute, coffee break, or whenever curiosity calls. I am Neda, your host for today's episode, and joining me is the one and only Naseel.
Hey everyone, welcome to the second episode of our Research Mastery series created in collaboration with the Internal Medicine Interest Group, or IMIG. In this episode, we're talking about one of the most important foundations in research study design.
Why does knowing study designs even matter? Like you might wonder, so what? Well, let's start from the very beginning. The study design is basically the architecture of a research project. It determines how data is collected, how bias is controlled, and whether the conclusions will be valid or misleading. The central question is always what is the most appropriate way to answer this specific research question? So, in practice, this means the research question should drive the choice of design, not vice versa.
Right, like you don't start by saying, I want to do a cross sectional study, and then try to force a random question into it.
Exactly. You start with the question first, then you ask, okay, what design actually fits this question best? Because a misaligned design can lead to systemic errors and weak conclusions, while an appropriate design strengthens validity and increases trust in your finding. All the downstream steps, data collection, analysis, and interpretation, depend on this foundational decision. Before we jump into study designs one by one, let's first talk about the types of research questions. Different research questions need different designs. If your question is descriptive, you're simply asking what exists. For example, how common is burnout among medical students? Or what are the characteristics of patients with a rare condition? These questions are usually answered using cross sectional studies or case series. Nasil, can you go over the analytical questions?
Sure, analytical questions are where you're not just describing anymore, you're asking whether two things are related. For example, is smoking associated with lung cancer, or is poor sleep associated with burnout? Depending on the situation, these can be studied using cross sectional, case control, or cohort designs. If the question becomes causal, meaning, does this exposure or treatment actually cause this outcome? Then randomized controlled trials are usually the strongest design, because randomization helps reduce confounding bias. If you're asking what happens over time, like what predicts complications in diabetic patients, that's usually a prognostic question, and cohort studies are often the best fit.
Another big picture distinction is the type of data you're working with. Quantitative research focuses on numbers like prevalence, scores, risks, rates, or treatment effects. Qualitative research focuses more on experiences and perception, usually through interviews, focus group, or open ended responses. Mixed methods combine both. For example, you might measure burnout using a validated scale, but also ask students to explain why they feel burnt out. So you get both the numbers and the context behind them.
And finally, studies can be observational or interventional. Observational studies, what do? They simply observe what is already happening, like cross sectional, case control, and cohort studies. The researcher does not assign an exposure or treatment.
These observational studies are usually more practical and beginner friendly, but they're more prone to bias and confounding, so they usually show associations rather than definite causation.
Interventional studies are different because the researcher actively assigns an intervention. The classic example is a randomized controlled trial, or RCT, where participants are randomly assigned to either a treatment group or a control group. This makes RCTs very strong for studying cause and effect, but they're also more expensive, complex, and not always ethical or feasible.
So the key idea is to start with the research question, then choose the design that actually fits it, not the other way around. Okay, now that we've elaborated on the types of research questions, let's shift our discussion to the main topic of this episode, starting with cross-sectional studies. From the name, cross-sectional studies means you're taking a cross-section of a population at one specific point in time.
It's like slicing into the population and looking at what exists at that exact moment. You're not following people over time, you're just capturing a snapshot.
Cross-sectional studies are useful for estimating prevalence and identifying associations, not causation. These are usually common in surveys and baseline assessments. For example, you might distribute a survey asking medical students how many hours they sleep and whether they experience burnout, Then look for an association between poor sleep and burnout.
And I'm sure you've all seen people begging for responses on Google Forms and WhatsApp groups.
Basically, every university group chat ever.
Cross sectional studies are popular because they're quick, practical, and cost effective. You don't need years of follow up or huge funding, which is why many beginners and medical students start with them. But the major limitation is that they lack temporality, meaning you cannot determine what came first, the exposure or the outcome.
If students with poor sleep also have burnout, you cannot say poor sleep caused burnout. Maybe burnout caused poor sleep, maybe another factor caused both. Because you cannot establish the sequence of events, you cannot establish causation. You can only say that they may be related in some way.
A critical point in cross sectional studies is how you measure your variables.
Variables are the things you're trying to measure or study, like depression, burnout, anxiety, sleep quality, blood pressure, or quality of life.
If you are assessing things like depression, anxiety, burnout, or quality of life, you should avoid creating vague, random, unvalidated questions unless you have a strong reason and proper validation.
Yes, you can't just send out a random form and assume it's scientifically reliable. You should use established validated tools whenever possible, like PHQ-9 for depression and GAD-7 for anxiety. Because if someone answers that they have anxiety, based on what are you making that conclusion? You can't just say 20% of our sample has anxiety, unless there's a validated tool backing that up. Otherwise, the results become questionable from the start.
What if a certain topic doesn't have a validated questionnaire?
If no standard questionnaire exists, especially for a niche topic, you can adapt one from a previously published study. Look for studies with similar research questions and see what tool they use. But if you adapt a tool, you may need permission from the original author, and you should clearly credit them.
We should also perform pilot testing for the questionnaire.
Exactly. And what do we mean when we say pilot testing? Pilot testing is when you try the questionnaire on a small sample first before officially distributing it. This helps identify confusing wording, unclear questions, technical issues, or anything participants might misunderstand before you collect full data.
Yes, and trust me, you do not want to spend a whole year collecting data only to later find out that your tool was not reliable or publishable.
Now, let's move to a case control studies. What do we mean by case control studies?
From the name, you have cases and controls. Cases are people who already have the disease or condition. Controls are people who do not have it. So, for example, one group of patients with lung cancer and another group, the control, without lung cancer. Then, you look backward to assess prior exposures. So you ask, did these patients have a history of smoking, asbestos exposure, radiation exposure, or occupational chemical exposure?
So, in case control, you start with the case or the disease first, and then you go to assess the exposure.
Case control studies are especially useful for rare diseases or diseases with long latency periods. Because if the disease is rare, it would take a very long time to wait for enough people to develop it naturally, and that would make it difficult to apply in a cohort study, where you track the incidence of disease in exposed versus unexposed.
If you have a rare disease, you start by gathering as many people affected by the disease as you need. So that way, you're starting with the cases, as in case control.
So, the main measure used in case control studies is the odds ratio.
In simple terms, the odds ratio compares how likely the cases have had prior exposure in comparison to the exposure in control. So, if smoking, the exposure, was much more common among patients with lung cancer, the cases, than among controls, meaning there's an association between smoking and lung cancer, then the odds ratio would be high.
And we use odds ratio in case control studies instead of relative risk because case control studies start with the disease, not with the exposure, and following people over time.
Yes, relative risk, which we use in cohort studies, requires you to know the actual risk of developing disease. How would we calculate that though?
To calculate that, you would need to start with exposed and unexposed groups, follow them over time, and see who develops the outcome. So, you start with the exposure and see if it causes a risk of developing the outcome.
But in a case control study, you cannot calculate the true probability or risk of developing the disease because you didn't start with the risk factor to begin with. Instead, You compare how common the prior exposure was in cases versus controls. That's why case control studies use odds ratio instead of relative risk.
If you're getting cases and asking them if they were exposed before, they may not remember accurately.
Yes, that's why case control studies are prone to recall bias, because participants may remember past exposures differently. Patients with the disease may think more carefully about previous exposures because they're trying to understand why they became sick, while controls may not remember as clearly. Case control studies are also prone to selection bias because controls should ideally represent the same population as the cases, except without the disease.
So, you can't just choose anyone to be a control. But, I mean, choosing truly comparable controls can be difficult.
Yes, but it's important because if the controls are not representative, the results can become misleading. Now, let's talk about cohort studies.
Cohort studies follow people based on exposure status, not disease status.
So instead of starting with people who already have the disease, you start with exposed versus unexposed groups. Then, follow them over time to see what outcomes develop.
For example, you could take smokers and non smokers, then follow both groups over time to see who develops lung cancer.
Precisely. Also, keep in mind that cohort studies can be prospective or retrospective.
Prospective looks at the future, and retrospective looks at the past.
Yes, so a prospective cohort means you start now and collect new data going forward. Retrospective means you use already existing records from the past. The events already happened, but you reconstruct the timeline using medical records or databases. You review participant files and charts to see who was exposed in the past. Say, for example, if they were smokers 10 years ago and you divide them into previous smokers versus non smokers according to their data from 10 years ago. Now you follow those two groups you created from their decade old data and see how they're doing now in the present.
You still started with the exposure, it just so happened to be in the past rather than now. So, prospective and retrospective are both still cohort studies, because both start with the exposure status and look at outcomes.
So the difference is whether the data are collected going forward or already existed before the study started. Cohort studies allow you to calculate incidence, meaning new cases over time. They also allow you to calculate relative risk.
Because now you're actually observing who has the risk of developing the outcome based on their exposure.
Cohort studies are also strong for establishing temporality. In other words, knowing what came first. Because you can see the exposure first, then the outcome later. This makes them useful for prognostic questions, like studying the risk of complications in diabetic patients over time, or whether uncontrolled hypertension, the exposure, increases future stroke risk, the outcome.
However, cohort studies need more time and resources, and they may suffer from loss to follow up, especially prospective. They can also still have confounding bias because the exposure is not randomized.
For example, if smokers develop more disease than non smokers, smoking may be part of the explanation. But smokers may also differ in diet, exercise, alcohol use, healthcare access, or other lifestyle factors. So, confounding means another factor is related to both the exposure and outcome, making the relationship harder to interpret.
It's like, sure, okay, the smokers got cancer, but you don't know if it was due to their smoking, or perhaps their diet, or some other environmental factor.
One practical point about retrospective studies, whether retrospective cohort or case control, is that they are very suitable when you have access to existing patient data, usually through hospital records or databases.
Usually, if you have access to a hospital database or patient information systems, you can easily get the hang of it. And if you're still new to the hospital environment, don't hesitate to ask seniors for help.
A lot of students assume it's complicated or inaccessible, but many times it's much easier once someone explains the process.
Another thing is that in retrospective studies, like any study, you must first define your inclusion criteria. For example, all adult patients admitted with pneumonia between 2020 and 2024.
Then, you identify the variables you want to collect, like ICU admission, mortality, smoking history, oxygen requirement, comorbidities, or length of hospital stay. Then you extract the data and analyze outcomes that already occurred.
And these studies are often more publishable than simple surveys because they involve real clinical patient data, but they depend heavily on database access, doctor support, and ethical approval.
Let's shift our discussion to a stronger study design, which is
The randomized control trials, or RCTs.
RCTs are considered the gold standard for evaluating interventions, like medications, vaccines, procedures, or treatment strategies.
And the reason they're so strong is because participants are randomly assigned into groups.
Usually, one group receives the intervention and the other receives either standard treatment, placebo, or another comparison. Randomization helps minimize confounding because it aims to balance known and unknown factors between groups.
Another important concept is allocation concealment.
This means that the researcher who is enrolling the participants into the study should not know what the next assignment will be before the patient enters the study.
Because if the researcher knows the next patient will receive the new treatment, they may unconsciously choose to enroll a healthier patient into that group.
And that will create selection bias from the beginning.
This allocation concealment is not the same as blinding. Blinding is different. Blinding happens after participants are assigned, and it means participants, investigators, or both do not know who is receiving the actual treatment and who is in the control group.
So, in other words, allocation concealment happens when you're placing the participants into groups, so you don't know which group they're getting placed into. While blinding happens when you actually give them the pills or the drug after they already assigned into groups, so you don't know whether this pill you're giving them right now is the treatment or a placebo.
So, just like we said that allocation concealment minimizes selection bias, blinding reduces measurement bias.
Exactly. For example, if participants know they are receiving the real treatment, they may report feeling better because of expectations. And if physicians know which patient received the treatment, they may unconsciously interpret outcomes more favorably.
RCTs provide the strongest evidence for causation, but they are expensive, complex, and sometimes unethical or impractical.
Like, you obviously cannot randomize people to smoke cigarettes for 20 years just to prove smoking causes lung cancer. Alright, we're heading into yet another study design. One of the biggest practical entry points. Commonly used by students is case reports because they are ideal when you encounter a unique or educational clinical case during clerkships or rotations.
Yes, like a rare condition, unusual presentation, unexpected response to treatment, or rare complication.
Exactly. And sometimes the doctors themselves will say, "This is very rare." And that's usually a clue that the case may be worth reporting. At that point, you can ask whether it's possible to work with them on a case report.
In practice, to confirm whether the case is worth writing, search the literature to see whether similar reports already exist. Then collect the patient's timeline, presentation, investigations, management, and outcome. Then, the discussion section explains why the case is important and how it compares with previous literature.
Case reports are a great starting point because they don't require complex statistical analysis, and they help build clinical reasoning, literature review, and scientific writing skills early on. If you're rotating through pediatrics, try to work on a pediatric case. If you're rotating through surgery, try to take a surgical case. By the end of the year, you may have several research experiences across different specialties.
And please don't get discouraged if doctors refuse.
It happens. Some doctors may prefer giving cases to residents or senior students, and that's okay. Just keep trying with different physicians and opportunities. Actually, go on a bit of a tangent here, but always try to generate ideas from clinical observations, not just for case reports. If you notice something unusual, repetitive, or unexpected in practice, it may be worth investigating. Maybe you notice an unusual side effect, a repeated complication, or a gap in how patients are managed.
But before jumping in, check the literature. See whether the question is truly novel, already answered, or still unclear.
The last study design we're discussing today is review articles, which are especially applicable for preclinical students without access to patients or databases. Review articles involve searching databases like PubMed, Scopus, Embase, Web of Science, or Google Scholar for existing studies on a topic. Then you organize and synthesize the evidence.
Synthesizing means combining findings into one overall understanding, not just summarizing paper after paper.
A strong review doesn't just say, "Study 1 found this." study 2 found this.
Definitely not.
It identifies patterns, compares findings, highlights contradictions, and explains gaps in the literature. For example, maybe one paper suggests seizures occurs through inflammatory pathways, while another focuses on neurotransmitter imbalance or genetic predisposition.
So, you compare where studies agree, where they differ, and what questions remain unanswered.
Yes, reading discussion sections of papers helps a lot because authors often explain limitations, conflict findings, and future directions there. Now, review articles are a broad category. They include narrative review, systematic reviews, and meta analysis.
Yeah, they're not all the same.
Narrative reviews are broader and more descriptive. Systematic reviews and meta analysis follow much stricter methods for searching, selecting, and analyzing studies.
We'll talk about systematic reviews and meta analyses in more detail in later episodes.
One very important tip, especially for review papers, is to stay organized early and document everything you do.
Projects can continue for months or even years, and trust me, you will forget things.
Suddenly, you'll have 10 Google documents, random screenshots, PDFs everywhere, and you won't remember where anything is. So, whether you use Notion, Google Documents, Google Sheets, Excel, or anything else, just create one big master sheet and document everything like your life depends on it.
And what exactly does that include, you may ask? Well, for reviews, keep track of 1. What databases you searched, 2. What search terms you used, 3. The years you included, 4. How many articles you screened, 5. Your inclusion and exclusion criteria, and 6. Who reviewed or extracted the data. When you are screening the articles, it helps to write a bit on each article that you read, because when you come back to it later on, it will make it so much easier to remember. And later, when you write the methods section, all of this becomes important.
Reviewers tend to ask about these details if they're missing. So, again, make sure everything is documented well.
Also, create tables early.
Even one or two good tables can summarize a huge amount of information quickly. This is one of the biggest values of review papers, giving readers a clear overview without forcing them to read every single paper themselves. You know, honestly, if you can do that for any project you work on in the future, create a master sheet where you compile everything in one place. You don't want to get lost in a million places and have to scroll through all chats and all that. Now that we've finally concluded our talk on study designs, we need to talk about ethics, which is a vital consideration before starting any human research.
The core ethical principles come from the Belmont framework, which is autonomy, beneficence, non-maleficence, and justice.
Autonomy means individuals should be treated as autonomous agents. In research, this means informed and voluntary consent.
Then you have beneficence and non-maleficence, meaning that research should maximize benefit and minimize harm.
And last but not least, justice, which means that the selection of participants should be fair, and the benefits and burdens of research should be distributed fairly.
Vulnerable groups like children, prisoners, and cognitively impaired patients need special protection.
Yes, which brings us to the IRB, or Institutional Review Board, sometimes called an ethics committee. Why do we even need IRB?
The IRB reviews research protocols to protect participants.
Most human studies, or studies using identifiable private data, require IRB approval before starting.
The IRB checks that risks are minimized, consent is appropriate, and privacy is protected.
A typical IRB submission includes the research protocol, consent forms, recruitment methods, and data protection plans. The level of ethical review depends on the risk. What do we mean by that? Low risk projects, like anonymous surveys or studies using de identified data, may qualify for exempt review. Minimal risk studies may undergo expedited review. However, higher risk studies, clinical trials, or studies involving vulnerable populations may need full board review.
Hence, understanding the IRB pathway early helps you plan your timeline realistically as you're working on your projects.
Exactly. Seeking IRB approval is very necessary because if you were to write a paper without IRB approval, when the approval was required, then that can prevent publication later on and all your work will go to waste.
There are some special cases. For example, routine case reports may sometimes fall outside formal research and are mainly educational. especially if they involve only 1 to 3 patients. However, policies vary, and journals may still ask for an IRB determination letter. So, when in doubt, ask your IRB early on.
And what about informed consent?
Valid consent means that participants understand the study purpose, procedures, risks, alternatives, and they understand that participation is voluntary. It should be clear, not full of technical jargon, and participants should know that they can withdraw at any time.
In retrospective studies that use de identified data, consent may sometimes be waived by the IRB because you don't need it if you can't even identify each single patient, but confidentiality must still be protected. Now, for all the designs we mentioned, another important concept is reporting guidelines. You don't need to memorize every detail, but you should understand their purpose.
Reporting guidelines are structured checklists that help make sure your paper is complete, clear, and transparent. So they're not there to make your life harder. They just remind you what is important information that should be included.
We have specific guidelines for different study designs. For observational studies, like cross-sectional case control, and cohort studies, you'll usually use STROBE. STROBE helps you report the study design, setting, participants, variables, bias, sample size, statistical methods, results, and limitations.
For randomized control trials, you use CONSORT. CONSORT focuses on randomization, allocation concealment, blinding, participant flow, and outcome measurement.
For systematic reviews and meta-analysis, you use Prisma. Prisma helps you report how you have searched the literature, selected studies, applied criteria, and synthesized the evidence.
You can look them up to learn more about them, but keep in mind that these checklists should be used at the planning stage, not after you've started writing your paper. Why? Because if you look at them only when you're already writing, you might realize too late that you forgot to define or collect a critical piece of information.
Now, let's talk briefly about measures of association and interpretation.
Different study designs use different statistical measures. Case control studies mainly use odds ratio because they start with disease status, so you cannot calculate true risk directly. On the other hand, cohort studies and randomized control trials can use relative risk, also called risk ratio, because you can observe who develops the outcome over time.
The way I like to remember it is that the word cohort has the letter O's in it. So the O's are similar, or in other words, they are related to each other. That's why we use relative risk for cohort studies, because the O's are related. But if you remember that the relative risk is for cohort, then by elimination, odds ratio is for case control.
I like that.
Another important measure is the hazard ratio, which is used in time to event survival analysis. Instead of only asking whether an event happened, it also asks how quickly the event happened over time. For example, in a heart failure study, patients in both groups may eventually end up hospitalized, but one treatment may delay hospitalization to a later time.
A hazard ratio compares the rate at which events occur between two groups during follow up.
If the hazard ratio is zero point 0.5, it means that at any point during the study, the treatment group is experiencing events at about half the rate of the control group. In simple terms, patients receiving the treatment tend to go longer before developing the event. So let's take a very specific, exaggerated example. It's like we are saying 50% of the treatment group were hospitalized after 2 months, while 100% of the control group were hospitalized after 2 months.
So, hazard ratios are useful when follow up time matters, just like in cancer survival, time to relapse, time to stroke, or time to death.
Another important concept is relative versus absolute measures. Sometimes the relative risk reduction sounds huge, even when the real world effect is small. For example, if a drug reduces risk from 2% to 1%, the absolute risk reduction is only 1%. But relatively, that's a 50% reduction because the risk was cut in half.
So, relative numbers can sound more dramatic than the actual clinical benefit, like saying that the risk was reduced by half relative to the original 2% risk, when really that's just 1%.
That's why absolute risk reduction and number needed to treat often give a clearer picture of real world impact.
Now, let's talk about the good old p-values and confidence intervals.
A p-value gives an idea of whether the observed result could be due to random chance. A small p-value suggests that the result would be unlikely to happen by chance alone, meaning that they are statistically significant. But p-values are not the whole story.
Yes, we also have confidence intervals. Those are often more informative because they show the possible range of the estimated result. A narrow confidence interval usually means that the estimated result is more precise. A wide interval means there's a wider range of possibilities, which suggests more uncertainty.
For measures like odds ratio or risk ratio, if the confidence interval crosses 1, the result is usually not statistically significant. For example, if a treatment has a risk ratio of zero point 0.8, but the 95% confidence interval ranges from zero point 0.5 to 1.3, the true effect could represent benefit, no effect, or even harm. Because the confidence interval includes 1, we cannot confidently conclude what a real difference exists between the groups. So don't look at the p-value alone. Also, look at the confidence interval and the clinical context. We always hear about bias, so let's go over that now.
Bias is a systematic error that distorts your results. We have different types of bias.
Selection bias happens when your study sample is not truly representative of the population you're trying to study.
Yes, like for example, if you only survey students from one elite university and then generalize the results to all medical students everywhere.
Meanwhile, information bias happens because of measurement errors or inaccurate data collection.
Like using faulty blood pressure machines that consistently give readings lower than the true value.
Yeah, that's information bias. Then, we also have recall bias, which happens when participants do not accurately remember past exposures, which is especially relevant in case control studies.
Because in case control studies, you ask the cases to recall if they were exposed in the past.
And finally, there is publication bias, which is when positive or statistically significant studies are more likely to get publishable, while negative studies are less visible.
So, the literature may make a treatment look better than it actually is. Alright, those were the types of bias. Now, what about confounding bias?
Confounding happens when a third factor is related to both the exposure and outcome.
Take, for example, smoking. Smoking may be associated with alcohol use and lung cancer. So, this makes it harder to isolate the effect of smoking alone.
It really does. And this is why randomization, blinding, careful sampling, and proper statistical adjustment are so important.
Now, I'm sure many of you have seen the evidence pyramid.
At the top, we have,
Meta analyses and systematic reviews, of course.
you guessed it. We usually have systematic reviews and meta analysis, especially those focusing on randomized controlled trials. Then, we have randomized controlled trials themselves, followed by observational studies like cohort, case control, and cross-sectional studies. Lower down are case series, case reports, and expert opinion.
But the hierarchy is not absolute. A badly designed RCT is not automatically better than a very well conducted cohort study.
Definitely. The quality of the study matters a lot. Applicability matters too. Sometimes a perfectly designed study may not apply to your actual patient population or clinical setting.
So, yes, higher levels of evidence are generally weighted more heavily, but you should always critically assess how well the study was conducted and whether it applies to your question.
One really important skill in research is learning how to move from a broad idea into a focused research question. And this is done using question building frameworks. Like maybe you notice many diabetic patients developing eye disease. That's still just a general observation. You now need to turn it into a specific research question that can actually be studied.
For forming research questions in quantitative or clinical research, one common framework is called PICO.
PICO basically helps organize the question into parts: P for population, I for intervention or exposure, C for comparison, and O for outcome. Okay, Naseel. I'll test you with a sample question and you give me the PICO element. In adults with type 2 diabetes, does poor long-term glucose control increase the risk of vision loss compared to patients with good glucose control?
Let's dig into it. So, in this case, type 2 diabetes is the population. Poor long term glucose control is the exposure. Patients with good glucose control would be the comparison. And finally, the outcome is the risk of vision loss. How did I do, Nada?
Perfect. You identified all the elements correctly.
PICO is especially useful for clinical, quantitative or intervention based studies because it helps clearly define what you're studying and what groups you're comparing. But not all research is numerical.
Yes, sometimes you're trying to understand experiences or perceptions instead. Like, how do medical students describe burnout during clinical years? That's not really a numbers question.
For those types of qualitative questions, another framework called SPIDER can work better.
Spider is more suited for studies exploring experiences, opinions, behaviors, or perceptions rather than numerical outcomes.
So, the main takeaway is simple. PICO is usually better for quantitative clinical questions, while SPIDER is more useful for qualitative research.
And that brings us to the end of today's episode. Remember, research designs is the foundation of the entire study. A good research question needs the right design, ethical planning, careful measurement, and realistic execution. That's it for today's episode of PodBites and IMIG Research Mastery Series.
Thank you for listening.
And we'll see you in the next episode of PodBites.